We're good to go? Okay. I think we're going to go ahead and get started, everybody, if we can. Feel free to eat your lunch while we're speaking. I'd like to welcome everyone to our presentation on caring for adults with congenital heart disease. My name is Colleen Rosenberg, and I'm the nurse manager of the Pediatric Cardiothoracic ICU at the University of Michigan. So happy Congenital Heart Awareness Month. As you may or may not know, it's Congenital Heart Awareness Month. February 14th, we celebrate, and I hope since you're here with us today, you're aware of congenital heart disease. So we're going to share a little bit more with you about that. So we have been, over the past year, embarking on a journey to educate ourselves and educate others on the care of this unique and challenging population. And so this is the next in our series of presentations about this topic. So we are excited about our presentation today. And let me tell you a little bit about our speaker. So today we're going to be hearing from Dr. Regine Carruthers. Regine's role is clinical pharmacy specialist in pediatric cardiology, and she also serves as an adjunct clinical instructor at the University of Michigan College of Pharmacy. She provides pharmacy services in the Pediatric Cardiothoracic ICU and in the general care area of CS-MAW Children's. And she also serves in that role for the heart transplant program and a pulmonary hypertension program. And Regine has been with the Congenital Heart Center since 2006. Regine's training includes undergraduate and graduate training at the University of Michigan, and as well 2 years of pharmacy residency, 1 year at Lucille Packard Children's Hospital in Stanford, and 1 year at the University of Michigan CS-MAW Children's Hospital, our home. So we are excited to hear from Dr. Carruthers today. Regine's presentation will be more applicable to the inpatient area, but we are excited to welcome our colleagues via REMIC Telehealth Network from Munson Health Center, as well as other remote satellite sites from UMHS, and we're hoping that you can have some valuable information from our presentation today. Our presentation will also be available. It is being video recorded, so when you are asked questions during the presentation, please wait until you are near a microphone so that we can record your question for the video recording. And the video recording will be available both internal to University of Michigan via the PCTU website, as well as externally via REMIC. We have it available by DVD. So some housekeeping issues. Dr. Carruthers would encourage you to have a very interactive discussion and be actively asking questions. And so we have 2 microphones available, one over on this side and one over on this side, and we'll get those to you if you have questions. And we have some coffee and water and cookies over here in the corner, so help yourself during the presentation. Feel free to eat your lunch, and we are excited to have you today, so thank you for coming. And after this presentation, look for continued presentations from this group. So without further ado, Dr. Carruthers.
Thank you, Colleen, for the introduction. And thank you all for coming today. Today, I'd like to talk about drug therapies and how they impact guidelines and standards of care when looking at our adult congenital heart patient. I have no conflicts of interest to disclose. During our discussion today, I'd like to review the guidelines that pertain to the management of pain, agitation, and delirium in the critically ill adult patient. I'd also like to review our institutional practice guidelines for dealing with alcohol withdrawal. Next, I will discuss the pharmacologic agents commonly used in the adult emergencies. And last, I'd like to describe the skip core measures that are applicable to our patient population. Each one of these learning objectives are very distinctly different, and so in between each one of the objectives, when I come to the end of that discussion, I will open it up for questions, but feel free to dialogue with me throughout the discussion. So I'd first like to talk about the guidelines published by the Society of Critical Care Medicine in January 2013. This was an update to guidelines that were pertaining to pain management, the treatment of sedation, as well as delirium in the adult critically ill patient population that was originally published in 2002. They embarked on this mission in 2006, and it took 6 years to come up with consensus guidelines for approaches to care in the critically ill patient. They ultimately provided statements and recommendations with regard to pain and analgesia, agitation and sedation, and delirium. They also provided strategies to optimize ICU outcomes. For the purpose of our discussion today, I'd like to really focus on delirium, but I will give some recommendations with regard to pain and sedation. So I'll begin by talking about pain. It is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pain is routinely experienced in our patients at rest and during routine care. What is well documented in the literature is that in the postoperative period, pain is not adequately managed in our patient population. And we do know that women experience more pain than men. There are negative sequelae that result from unrelieved pain in the ICU environment. They include both physiologic and psychological outcomes. I would like to highlight our long-term outcomes that are affected by unrelieved pain. They include a higher incidence of chronic pain, symptoms of PTSD, as well as lower health-related quality of life scores. So how do we minimize these adverse sequelae that we see from untreated pain? Probably the most important thing is assessment tools. The tool that we commonly use in our intubated patients are the behavioral pain scale, which in the guidelines has been proven to be one of the most valid and reliable scoring tools in the ICU. We also make use of the numeric scale, which is more applicable to patients that are not intubated. With routine assessment, we do know that our clinical outcomes can be positively impacted. We can see a decrease in the amount of pain medication required by our patients, decreased time on the ventilator, as well as decreased length of stay within the ICU. What are our treatment options for treating pain in the ICU environment? Many of you guys already have much experience with our approaches to pain in our postoperative patients, but the guidelines do highlight that when looking at opioid therapy in combination with adjuvant therapy, that you have the best pain management that you can have for a patient. We commonly use morphine in our ICU, but fentanyl and hydromorphine are considered to be just as efficacious in pain management. When thinking about how we should approach pain control in our patients, you can think about either continuous exposure or through a continuous infusion or intermittent dosing of pain medications. Guidelines recommend that we should utilize continuous infusion pain medications in the immediate post-op period of time because pain management and pain control is best achieved using continuous infusions. When we think about our adjuvant agents, acetaminophen and nonsteroidal anti-inflammatories are really our go-to agents. When we first think about IV or oral or rectal acetaminophen, we do know that IV is the most recent formulation to come to the market with regard to acetaminophen. Unfortunately, at our institution, it has not received approval for use in patients that are greater than 18 years of age. As a result, we commonly use oral or rectal acetaminophen in the immediate post-op period of time. We have found to have good results with regard to using opioids in combination to acetaminophen. One of the practice changes that we've seen really evolve over the last 18 months or so is the use of our nonsteroidal anti-inflammatory agents in our patient population. This may be in part due to the re-entry of ketorolac to the market since the shortage that we experienced about 2 years ago. But it really does enhance our ability to provide adequate pain control for our patients while minimizing opioid exposure. So adjuvant therapies will minimize opioid exposure as well as enhance the effects of our opioids. Next, I'd like to talk about agitation and anxiety that are commonly seen in our patients in the ICU environment. Common causes include unrelieved pain, hypoxia, delirium, hypotension, or withdrawal from substances such as alcohol. Prompt identification and treatment of agitation and anxiety are very important to the clinical outcomes of our patients. We commonly use the RASS score, which has also been validated and considered to be reliable by the guidelines in our patient population. In identifying that our patients have anxiety and agitation, it is important that we know what level of sedation we want to achieve when instituting therapy in our patients. Per the guidelines, it has been shown that light levels of sedation are probably the best form of sedation that we can provide for our patients, as it is associated with a shorter duration on the ventilator as well as a shorter ICU length of stay. So what agents should we consider? I've really categorized these into two categories, our non-benzodiazepine class as well as our benzodiazepine class. So I'd first like to talk about our non-benzodiazepines, including propofol and dexmedetomidine. For a long period of time, propofol was considered to be a go-to sedative agent in the adult population. Very, very different than us as pediatric practitioners have routinely thought of, where we really shy away from long-term use of propofol, and this is due in part to the increasing incidence and risk for developing propofol syndrome. This was really considered up until recent times, the last couple of years, to be strictly a pediatric phenomenon. But there have been many case reports in recent times of propofol syndrome in the adult population, which has really shifted practice amongst the adult clinicians in the ICU environment to limit use to short-term sedation with propofol. With the decline of use of propofol for long-term sedation, we have seen the increasing use of dexmedetomidine. And this is not necessarily what many practitioners in adult ICUs wanted to see because of the associated increased cost that comes with dexmedetomidine. Dexmedetomidine was brought to the market originally for short-term sedation in the adult ICU patient for less than 24 hours. They do have evolving evidence of longer-term use in the adult population. It in nowhere compares to the type of experience that we have in the pediatric population, where we'll use it for weeks and months on end. Longest reports in the literature for use of dexmedetomidine is approximately 3 weeks. In addition, they do not use doses as high as we do in our pediatric population. The dosing range for adult patients is 0.3 to 1.5 micrograms per kilogram per hour, which in contrast to pediatric patients where we often use somewhere between 2 and 3 micrograms per kilogram per hour as our max. Next, I'd like to talk about the benzodiazepine class. The benzodiazepine class is just as efficacious as dexmedetomidine when looking at its sedative properties. It, although, has begun to fall out of favor because of some associations with the incidence of delirium, in contrast to what we would see with dexmedetomidine or other non-benzodiazepines. As a result, the guidelines suggest, and I highlight suggest because they have not gone as far as to make a strong recommendation because the literature is not there to confirm that benzodiazepines are associated in absoluteness to delirium, but they suggest using non-benzodiazepines as a sedative agent preferentially over benzodiazepines. So I've talked and just began to highlight about delirium and some of the adverse effects that come along with it. So now I'd like to talk about delirium a little bit more in depth than I have with regard to pain and sedation. And I think this is a phenomenon and a disease that we see oftentimes in our patients, but we are not as familiar or as readily comfortable with dealing with and treating delirium in the post-op ICU patient. Delirium is a syndrome characterized by the acute onset of cerebral dysfunction and a change or fluctuation in baseline mental status. You can also see an inattention and either disorganized thinking or an altered level of consciousness in our patients. It can occur in the intubated or the unintubated patient, but we do know that it affects up to 80% of patients that are mechanically ventilated. The underlying pathophysiology of delirium, although, is unknown. There are several features to delirium. The first is that you will have a patient really present with a lack of clarity or awareness of their environment. And we describe this as a disturbed level of consciousness with a reduced ability to focus, sustain, or shift attention. You also can see a change in cognition or the development of perceptual disturbance, which we often identify as hallucinations or delusions in our patients. Other symptoms that come along with delirium include sleep disturbance, abnormal psychomotor activity, as well as emotional disturbances. Probably the things when I think about emotional disturbances that the nursing staff will often report to us is that the patient is fearful, they're really, really anxious, or they have this waxing of waning where they're really, really high or they're really, really low and have more of a depressive affect. We also can see the patients become very angry and violent, all of which can be attributed to symptoms of delirium. There are two subtypes of delirium. There's hyperactive delirium and there's hypoactive delirium, where hyperactive delirium comes along with a patient that is agitated and is commonly associated with hallucinations and delusions. For the hypoactive delirium, this is the most misdiagnosed form of delirium that we see in our patients. And they really have a calmness and a kind of a lethargic appearance, and it's commonly associated with confusion and sedation. So what are the risk factors for developing delirium? These here, some of them make sense to me, and some of them I think we just have to really know that this is what we're looking for our in our patients. So if they have pre-existing dementia, a history of hypertension, a history of alcoholism, or a high severity of illness upon admission, they're going to be at increased risk and considered to be at high risk for developing delirium during their ICU stay. Unfortunately, one would think that age would have a direct correlation with the development of delirium, but this association has not yet been made. So why is delirium such a big deal? Outside of the fact that when the patient has delirium in the ICU, that they are somewhat difficult to care for, they can be concerning to care for if they're in the depressive state. But we also know that delirium negatively impacts clinical outcomes, where we've seen an increase in mortality reported in the literature, as well as increased length of stay, increased cost of care, and long-term cognitive impairment. And I think what's most significant when you think about the long-term cognitive impairment, when they've gone back and looked at patients that have experienced delirium at 3 and 12 months out from their hospital stay, they have not returned to their baseline activity levels, some of which have not left rehab centers or have not even returned to work. As a result of the long-term effects that come with the incidence of delirium, it's really important for us to be kind of ahead of the game when looking for delirium. And as a result, the guidelines recommend routine monitoring for delirium at least once a shift, especially in patients at moderate or high risk for developing delirium. Probably the best tool that can be used to identify patients early on is the CAM ICU assessment tool, which has been validated and considered to be reliable in the guidelines. And the CAM ICU is what we use in our ICU environment. There are pharmacologic and there are non-pharmacologic options to treating delirium. The non-pharmacologic options really are to provide sedation holidays for our patients, which are not always possible in our postoperative patient, or to have early mobility of our patients, which also, when you think about the high-risk patients who are still on the ventilator, are not going to be strategies that we can utilize in our patients. You also want to ask yourself, well, can we prevent this by any means? Pharmacologic, non-pharmacologic. There currently are no preventative medications being recommended by the guidelines to try and prevent delirium. Treatment options really fall into the class of the antipsychotics. The first antipsychotic that can be used in the treatment of delirium is haloperidol, and it is one of the typical antipsychotics. And although may be effective in treating the symptoms of delirium, has not proven to reduce the duration of delirium in current studies. As a result, the guidelines have not really made a recommendation to use haloperidol in the treatment of delirium, which is a change from the 2002 guidelines. Even so, we don't have much to go by, and as a result, in current practice, haloperidol is still being recommended and used in the treatment of delirium. There are some studies that are evolving looking at the prevention of delirium in the elderly, but they are very small studies that cannot be generalizable out to the general population. Haloperidol also is not a clean medication in that it has two side effects that really we must consider when approaching, in that you can see extrapyramidal symptoms as well as QT prolongation. The guidelines do make a strong statement against use of this agent in any patient that's at risk for QT prolongation or in patients that have other medications that may prolong the QT. As being many representatives from the cardiac group, we know that we can't always avoid drugs that prolong the QT. And so I think this is a medication that we have to consider on a case-by-case basis and make sure that we're monitoring appropriately our patients to minimize toxicity. Quetiapine is the other antipsychotic agent that can be used. It's one of the two atypical antipsychotics, and it may be effective in reducing the duration of delirium in our patient population. Unfortunately, we only have one study of looking at quetiapine in the treatment of delirium, and it contained 36 patients. It was added to as-needed haloperidol, and they did show a quicker resolution of delirium, decreased agitation, and an increased rate of transfer from the hospital to a home or rehab center. The limitation, although, was the small patient population. Despite this limitation, quetiapine has been added to the standard of care for our patients in the treatment of delirium. And so it is very common for our adult psych group to recommend the use of quetiapine and haloperidol as needed for our patients that develop delirium. There is a risk for QT prolongation, similar risk to that of haloperidol, but we do not see the EPS symptoms that we see with haloperidol from quetiapine. The second antipsychotic agent that can be used in the treatment of delirium is ziprasidone. It is not discussed in the guidelines, but there are two studies that have been, one study that's been completed and one study that's underway. The first study was the MIND study, and it was a randomized double-blind placebo-controlled trial that compared haloperidol to ziprasidone to placebo. The antipsychotics did not improve the number of days alive without delirium or coma in this patient population. Again, the sample size was a limitation in that it only contained 101 patients. Due to our need to really identify effective agents, the MIND-2 study was undertaken in 2012 and is actively enrolling patients at this time. It is a multi-center double-blind placebo-controlled trial comparing, again, haloperidol, ziprasidone, and placebo. And they're evaluating both long-term and short-term effects of delirium in patients. They are looking to enroll approximately 200 patients in each one of the treatment arms and are hoping to have data that is actually going to impact clinical practice. For completion's sake, I've concluded rivastigmine in our discussion, although it is not recommended currently at this time. There were several studies that were conducted leading up to the publication of the 2013 guidelines, which had to be prematurely closed due to adverse effects, as well as to increased risk for our patients because they did not see any difference between rivastigmine and placebo in the treatment of delirium. So that brings me to the end of the discussion of looking at the guidelines with regard to pain, agitation, and delirium. I'd like to open it up to questions to see if anybody has any questions with regard to the information just covered. Okay, I'm going to move on to the next.
It sounds like maybe these things really don't work.
Tim, we're just going to have you step up to the microphone so the question can be captured.
I mean, the take-home point, at least in the last couple drugs, which are still under study, is that they're probably not that effective.
Correct.
And it's probably non-pharmacologic therapy, which is going to work for these patients. Do you agree with that?
I agree with that. So I think that when you talk about symptom management of the patients, you can control some of the symptoms and you can make them a little bit more easily able to provide care to them, but it does not actually decrease the duration of delirium. We don't have a go-to agent at this point in time. No gold standard agent for sure. Thank you. So next I'll talk about the institutional guidelines for alcohol withdrawal. I've included here a link to the website that has all of the references, and they are really complete in that there's an overview of the Michigan alcohol withdrawal guidelines. There's also the assessment tool that is available and the instructions for clinician and nursing staff when approaching a patient that is experiencing alcohol withdrawal. The MAW guidelines were developed to be applied to patients that are greater than 18 years of age. And there are several steps that need to be taken to initiate the process of following through with the MAW guidelines. The first is that you have to screen for alcohol usage. So nursing staff should be looking at the admission assessment, looking for how the patient responded to the alcohol utilization question, as well as clinicians should be evaluating for excessive alcohol use either via the CAGE questionnaire that they can ask the patients to find out if they have problems with alcohol use, or by patient report. As you can imagine, when you look at these two steps that have to be taken to even get the process started, you have to know that the patient is at risk for alcohol withdrawal. You have to rely on either accurate information or the patient being honest. And so what the adults have found, even here at our system, is that they are missing the boat on many of their patients who cannot provide honest answers or are not willing to provide honest answers. And they're finding themselves dealing with moderate to severe alcohol withdrawal even before they can even try to get on top of it, requiring patients to be transferred to the ICU. As a result, the group that met to originally put these guidelines together are again meeting to talk about how they can actually identify patients earlier on to try and minimize some of the adverse effects that they see in patients. In my experience here, this hasn't been something that has come up as much, but I think it's something that we have to think about, and that we have our colleagues that are really screening for our patients to see if they have alcohol utilization, but being aware that these guidelines are only going to be effective if we're able to identify the patients. So once you've identified that your patient qualifies for the MAWS assessment, we want to actually initiate use of the tool. And I apologize if you can't hear this, but if you can't read it, but I'm going to highlight a couple of things. So here at the very first set of questions really focuses on questions that are going to identify symptoms that are associated with CNS excitation. And we call those our type A symptoms. The second set of questions are going to deal with type B symptoms, which are going to be dealing with adrenergic adverse effects that can be occurring in our patients. Lastly, our type C, which are going to be associated with our patients that are going to have symptoms of delirium. Once the nursing staff has evaluated a patient and assessed them, and we have our scores, we know that if we have a score of less than or equal to 1, that the potential for alcohol withdrawal is non-existent to minimal. If they have a score of 2 to 5, they may be experiencing mild to moderate alcohol withdrawal. And a score of greater than 6 will be associated with severe alcohol withdrawal. The clinician instructions are very, very involved, as well as the nursing instructions are very involved. And so the frequency of assessment is dependent on the severity of withdrawal. I would refer the nursing staff and also the clinician group to the nursing instructions and the flow diagrams to see the specific instructions with regard to what type of withdrawal you're looking at and how frequent your assessments need to be done. Treatment options in dealing with alcohol withdrawal really are predicated on the type of symptoms that you're seeing. So if you're seeing type A, B, or C symptoms. If you're seeing type A symptoms associated with CNS excitation, the treatment of choice is going to be lorazepam. If you're dealing with type B symptoms or adrenergic hyperactivity, you want to use clonidine. And if you're dealing with type C symptoms associated with delirium, haloperidol is going to be the go-to agent. Specific recommendations with regard to medication and dose are contained within the document for clinicians. And the doses and the agents are going to be variable depending upon if you see one type of symptom in isolation or if you're seeing a combination of symptoms, and also considering what your hemodynamic status of your patient are, because the combination of how they will use them and the doses that are recommended are going to be based on some of the hemodynamics and vital sign readings of your particular patient. So that's an overview of the MAW guidelines. Are there questions about this? I know this has been something that has come up recently with us seeing more and more of the adult congenitals being operated on and just comfort level with the guidelines. Mm-hmm. Have you stepped to microphone?
What about when you talk about the admission assessment? Oftentimes, we get the patient in the ICU and none of that has been completed. So we're starting at ground zero with no information because they can't answer the questions, they're sedated. So is there something in place or something we can do to have that happen ahead of time?
There's nothing in place currently. But this is what the group is currently meeting to discuss, because they are finding that they're behind the ball, and before they know it, they're dealing with type B and C symptoms. And so they're looking at how can we better identify these patients, either at tools during the initial assessment when they present, or through education to the practitioners who are going to be setting the patients up for surgery. Other questions?
So I realize the discussion is mostly for adults, but we have young children, younger teenagers and younger that use alcohol. I mean, this is not on our assessment tool currently, and I don't even know how to access this thing. So, I mean, is there going to be some implementation for that, or some way of doing that?
Current guidelines are really only applicable to patients that are greater than 18 years of age. This is something else that's being discussed. I had a long conversation with the pharmacy representative on this group, is that we are seeing alcoholism and alcohol abuse in younger patients, and what do we do, and how do we extrapolate these guidelines? I think probably the biggest thing that we're going to have to deal with in some of the shortcomings is when you look at the type of dosing of the agents within the guidelines, they're pretty aggressive dosing. And so if you take a patient that has never been exposed to a lot of these drugs that can be respiratory depressants, how do we manage those? What is going to be the ideal dose? And that data just isn't out there with regard to managing those symptoms as well, and then balancing the side effect profile of the medications. I think even when we look at clonidine as an agent, it's not a clean drug, and that it's not easy for us to use in our patients. The most common dosage form is going to be using the patch formulation, which if you have a smaller patient, how do you adjust that dosage? We do know that intermittent dosing of clonidine gives you, your peaks and your valleys. And so what does that mean as far as controlling symptoms when you have patients that have, adrenergic effects? And so I think there's a lot of things that go into that discussion that haven't been had, because this is a relatively new phenomenon, and we don't know how to approach an adult patient, let alone a pediatric patient. Other questions? Okay. Thanks for those questions. Next, I'd like to talk about medications that are used in the adult emergency. And this came to mind to think about and talk about with you guys, is because I often hear when we have an adult patient come back, oh my goodness, that's an adult patient. I don't know if something goes wrong. How do I resuscitate this patient? And so I thought I'd approach by looking at the PALS and ACLS algorithms and what really are the differences and similarities between the guidelines. If you look at the algorithms for cardiac arrest in ACLS and PALS, they are completely identical. And I think that's important for us all to know, because I think that's the scenario that makes people most nervous when having an adult patient come back and they're critically ill on lots of pressors, and you know that they're riding right there on a fine line between being stable and being unstable. And so I highlight that for you. The biggest differences in the guidelines come with regard to bradycardia and tachycardia with a pulse, as well as with acute coronary syndromes and stroke algorithms. And the ACS and stroke guidelines are a talk in and of itself and way beyond the scope of a talk like this. And so I'm not going to delve into that, but I do highlight that we do have a stroke team here that is on page, and we do utilize them in times we've needed to in our ICU environment. And then for our ACS guidelines, that this is something that we just may need to go back and think about, how do we want to approach if we were to see this in one of our patients. But well beyond the scope when you talk about the therapies that are used within these algorithms. So with that, I'd like to first talk about the algorithm for bradycardia with a pulse. And the biggest difference when you begin to think about initiating pharmacologic treatment options is what is your go-to therapy in PALS versus ACLS. In PALS, the go-to agent is going to be epinephrine. In contrast to in the ACLS guidelines and in this algorithm, they would go to using atropine first line. And then when they do think about their second line agents, they would then consider dopamine or epinephrine, but it would be via a continuous infusion, which is not similar to what we would use in a pediatric patient, where we would actually just use a cold dose of epi. So that's the major difference within the bradycardia with the pulse algorithm. When we look at our tachycardia with the pulse guidelines, the difference comes with regard to the antiarrhythmics that are recommended in the ACLS guidelines. And I apologize if you can't read it very clearly, but one of the biggest differences is that in the PALS guidelines, we use amiodarone and procainamide when a antiarrhythmic infusion is required. In the ACLS guidelines, they too recommend procainamide and amiodarone, but they also will recommend sotalol for use in our patients. And so this will be a different therapy, and it's highlighted right down here. The other difference is that they will make use of a calcium channel blocker or a beta blocker in patients that have tachyarrhythmias, which we don't commonly use in our pediatric patient population and is not included in the PALS algorithm. So when I think about the medications that can be used in adult emergencies, I think about having a definite role versus a questionable role. And I think we can all agree that the medications that are in the list of definite role, including cold dose epinephrine, calcium chloride, adenosine, atropine, amiodarone, procainamide, and sotalol all fall within the purview of resuscitating an adult congenital patient. I think what probably brings into question is the use of epinephrine spritzers. And for those of you that are here or tuning in that are not as familiar with epinephrine spritzers, this is when we administer 1/10 of the cold dose to our patients, and we don't give the full cold dose at any particular point in time. And there are reasons for which we do this, and that we want to try and not have a complete we don't want to see the adverse effect of tachycardia in our patients, and we want to see if we can actually have a blood pressure effect without seeing that adverse effect. But when you go to other ICUs, this isn't a practice that would be commonly used in resuscitating an adult patient who is needing CPR. In addition, sodium bicarb is not routinely used. One of the things that me and my colleague often say when we think about sodium bicarb is that it often just makes us feel better. But we are seeing that the pediatric guidelines are following suit with the adults, and that bicarb isn't commonly used in the resuscitation of adult patients. With that, I'd like to open it up with questions.
Dr. Carruthers, could you comment on the code cart and just the absolute quantity of medication as far as duration of code that can be sustained?
Mm-hmm. So the code carts that we have over here in our children's hospital are completely identical to the code boxes that we have on the adult side. And so the number of medications in there with regard to being able to resuscitate an adult patient are probably enough to go through probably somewhere between like 30 to 45 minutes. But there's plenty of medications in there, and it's not completely delineated for just pediatric codes. You'll have the adult code medications as well as pediatric medications in there.
I have a question too. I know in the ICU, in that immediate post-op period in the adult, there's always hesitation to give code doses of epi because we're afraid to overshoot the blood pressure and then do some damage to the operative site. Do you have any comments on that?
I think that it definitely is a case-by-case scenario, and I think that when you think about the surgical procedures that we see in our side, they're going to be completely different than the clinical scenarios that you see in the other ICUs. I think the one thing we keep in mind when we talk about epi spritzers is making sure that people are aware why we're using them and what scenarios we want to use them. And when you have someone that's floating through and not as familiar with why we use it, making sure that we provide that education. But I think there's definitely a role in our group. I think that when you look to the guidelines for ACLS, they will not have any discussion of, epi spritzers or whatever you want to call them, because there's different verbiage out there. And so being aware that that is a distinct difference for our patient population, but the rationale behind it is important. Other questions? Okay. Next, I'll talk about the skip core measures, and this is something that we've been monitored and assessed for probably at least for the last 5 or so years. And this happened a lot of times on the background with us putting things into place with regard to our CareLink system or Notion protocols without much knowledge of why we do these things. And so I wanted to highlight the skip core measures that have pharmacologic agents involved in them. The 4 skip core measures that really involve pharmacologic therapies is our post-op antibiotics, blood glucose, which is a measure that was revised and put into place in January of this year for VTE and also for beta blockers. So first we'll talk about prophylactic antibiotics, and I think this one's important to highlight what is the time frame in which post-op antibiotics should be used in our patients. The guideline is specific in that you should only have prophylactic antibiotics on board in our patients following cardiac surgery for 48 hours following the end of anesthesia time, not since they've come up to the unit, and not 48 hours of antibiotics themselves. And so some of you will commonly see me looking in the records and then saying, hey, can you DC that last dose of antibiotics? And the reason for that is because I recognize that we're we're getting close to that 48-hour mark where we actually will not meet the skip core measure. As a result, in the MCHC, we've adjusted our antibiotic regimens, and you'll see this in that cefazolin should only be used for 5 doses. We originally started off with 6 doses, but we did have several cases that didn't meet the core measure because the post-op antibiotic order set and antibiotics were not initiated until 6 to 8 hours after the patient's end of anesthesia time, and so we missed the core measure by just a couple of hours. So we revised that for all the antibiotics so that it's actually one shy of what you would think of as a 48-hour interval. Next, we'll talk about the new skip core measure for blood glucose. And I say bear with me because I'm going to try to explain this as easy as possible because it is very involved. And if you have any questions, don't hesitate to ask. With the skip core measure, the goal is that we must have a blood glucose that is less than 180 between 18 and 24 hours after the end of anesthesia time. If there isn't a blood glucose collected during that time frame, when they go back to assess for this skip core measure, they will actually look at the time period 12 to 18 hours after the end of anesthesia time. So with this, what they consider to be a passing score is if you have a blood glucose during the time frame that is less than 180. If you have a single blood glucose that is greater than 180, then you need to have a second blood glucose that is less than 180 during that time frame. And those two criteria are considered to be passing. What's not passing is if you have a patient that has a blood glucose that is greater than 180 and no subsequent recheck, or if you have a patient where you say, we're greater than 180, I'm going to initiate therapy, I'm still greater than 180, and you're within that time frame, then that is considered a fail. If you don't have any blood glucoses at all, of course, you can imagine that's going to be a fail. So when we thought about this, probably the one thing that gets us into trouble here is if we have 2 repeats greater than 180. And so when we devised our plan of action for looking at our MCH practice and how we wanted to roll this out, we decided that we would actually try to target that 12 to 18 hour period of time for initiating our first glucose check. The best way for us to operationalize this was to have a pre-check selection for a blood glucose level at 12 a.m. and one at T+12, which is going to be the time in which the post-op order set was entered plus 12 hours, which should put us somewhere in that 12 to 18 hour time period post-anesthesia time. If you have a patient that has gone to the OR and come back before 12 p.m., then we know that you don't necessarily need that T+12 hour blood glucose check. It is also important for nursing to know that we don't want us to clump or to put all of our levels together, labs and things like that, that we do need these even if they're in isolation from the other labs that need to be drawn for the day. The other thing I want to highlight is we did develop flow charts once we have these 2 levels to work from. And we have decided as a group that we would like to initiate therapy when patients have blood glucose levels that are greater than 150 and not the 180. So there's 3 algorithms, and I'm just going to highlight in this algorithm. This is when we start off with a 12 a.m. glucose. What you would do with the glucose level, and this is going to be between the nurse at the bedside and the fellow that's either there or who was on call most oftentimes. And so you have your 12 a.m. glucose. If you're 80 to 150, then you may need to recheck at that T-12 hours if that 12 a.m. is before the 12-hour mark post anesthesia time. If you're 80 to 150 and you're less than 80, then you need to give dextrose. If you're greater than 150, then you want to initiate using the sliding scale insulin that we use in the ICU environment. And this is the same the same sliding scale that we use over in the CVC, so comparable care to what adult post-op cardiacs are getting across the institution. If you have a patient that has the T plus 12-hour glucose and they're in the 80 to 150, then there's no need to recheck unless there is some clinical reason to do so. Again, if they're greater than 150, here you would initiate the protocol and then check at the T plus 18-hour mark. We hope not to get to this point if we have to check if the first initial one is at T plus 18 hours, because this really will increase our risk for not passing the core measure. So next I'll talk about the VTE skip core measure, and this applies to surgery patients who received appropriate VTE prophylaxis within 24 hours prior to surgery and 24 hours after surgery. It is important to note that our patients do not qualify for this skip core measure. The core measure that they actually qualify for is the global VTE measure. And this applies to all patients 18 years of age or older who have a length of stay of 2 to 120 days. Adult cardiac patients are exempt to the skip core measure, but they're eligible for the global VTE measure. And this is the one that is considered to be house-wide and includes SCDs as well as pharmacologic therapy. The global VTE measure has 3 subpopulations. They look at patients who don't have a VTE and want to ensure that they have adequate prophylaxis. They look at patients that have a VTE upon admission and making sure that they have appropriate therapy continued, as well as patients who have hospital-acquired VTE, in which they focus on if they are receiving appropriate treatment and also if they had a preventable VTE, in that were they on prophylaxis, was it appropriate prophylaxis, or were they not on appropriate prophylaxis? Lastly, I'd like to talk about the skip core measure for patients who come to surgery and they are on beta blockers preoperatively. And this core measure is really looking to ensure that beta blockers are restarted on post-op day 0 or post-op day 1. Our MCHC practice is going to be to document the reasoning for holding in the progress note, and this will actually meet the core measure for exemption. Without that documentation, we have an automatic fail to this core measure. So with that, I'd like to open the floor for questions with regard to the skip core measures.
Question is, I understand the VTE and I understand the glucose and the other one. I don't understand the antibiotics. What happened? What happened with antibiotics that we went from, a long time ago, keeping them on there until basically their chest tube came out or something, but we changed to 48 hours. What went on that made that change?
It was part of the quality improvement program. And I think a lot of that's going to be associated with just the increase in resistance that we see when you have added exposure to antibiotics, and so it may be helping the resistance antibiograms. But we haven't seen much infection in our patients at those surgical sites when we remove them. And this doesn't apply to patients that have like open chest. This is really for our patients going to be applicable to patients that need chest tube prophylaxis. But if you have open chest, we can maintain the therapy for much longer. The same goes true for VADs.
Regine?
Question.
I was just curious with the alcohol withdrawal guidelines. If on admission we know that that they have a high score, is there going to be an order set or something that when they start showing signs postoperatively that will have something to start controlling it right away?
So within the nursing instructions and also the clinician instructions, there's actually separate booklets that exist. So there are hard copies, as well as there's an order set that we can initiate. But within those step-by-step, at the step-by-step phases, there's recommendations upon what you should be doing with regard to therapy. Yep. But there is an order set. But the order set will give you your options, but it's not going to necessarily guide you through the various steps. So that's why the flow diagrams and the clinician instructions and the nursing instructions are going to be important for us to have. We had a potential patient a couple weeks ago, and we made sure to have those resources available to the nursing staff, as well as making available the link to the website where you can download those. In the case where it's someone we don't know of, and then once you get in there and you get the history, you're like, you need to get started, that you can access those documents.
Can I ask a question about the glucose control? You said if we have 2 levels, 2 greater than 180, it's an automatic fail.
Automatic fail if you're between 18 and 24 hours.
Even if we have initiated the insulin and we just haven't gotten to the right level yet, it's still a fail.
Correct. Which is why we are targeting the 12 to 18 hour, because you can have 2 glucoses greater than 180 in that period, but you can't have greater than 180 in the 18 to 24 hour period.
Are the adults less likely to vacillate high and low as much as the pediatric or younger kids are? Or is there more, do they react as quickly or as acutely to the insulin?
I think it depends on the severity of illness of the patient, but we do know that the insulin protocol that we use has been tested a long period of time in the adult patient population, especially the CVC population, and so that guideline has been tweaked and is actually coming up for another revision in the next couple of weeks, where we'll see another update where they're responding to data following use of the protocol, and so that protocol has been fine tweaked to consider those patient differences. Other questions? Okay. Well, I would open it up for generalized questions if you have them. Otherwise, I'd like to thank you for coming today.